counties are still maintaining more conservative reopening policies than the state. While hospitalizations and deaths continue to trend down, we still haven't reached the benchmarks initially set out by the administration for reopening. Today, we are finally joined by the State Department of Health officials to update the legislature on the COVID crisis. On a personal note, I am deeply concerned about what's happening in our country right now. The peaceful protests that have occurred across Maryland have warmed my heart. Our young people have lived up to our standards and modeled for the rest of the country what peaceful protests look like. I want to especially thank Dr. Mohan Suntha for his donation of masks to the protesters to keep people safe during these protests. Do not mistake what people are protesting and what we are fighting for, a change in a systemic racial injustice that has hurt, killed, and held down so many Black Americans. The House is committed to passing systemic policing reform in the 2021 legislative session. We are committed to giving people hope and investing in jobs and education so that every Marylander has a better future to look forward to. With that, Mr. President.
Thank you, Madam Speaker. Well stated. As the speaker mentioned, we are joined today by the Department of Health. Before we jump to that, I just wanted to take a quick moment as well on a sort of point of personal privilege that this is a really precarious, emotional, and difficult time for our country, for our state, and for each individual neighborhood that all of us represent. There are a lot of questions about the future, about what our democracy looks like, about our institutions. And it is processes like this. It is the legislative branch that is reviewing and overseeing the emergency alongside of the executive that is essential to restore faith and trust in the institutions that we are all a part of. That said, we had some unbelievable, extraordinary representations of democracy this last week and over this weekend in the last couple of days across the state of Maryland. Thousands and thousands of Marylanders demanded better of their government. And we owe a duty to make sure that those voices are heard. And what we asked was that peaceful demonstration be represented and that the voices be used at the ballot box. Well, yesterday was that opportunity. We are in the midst of a pandemic. And so there, of course, will be certain hiccups that are to be expected in a totally new process. We still have a lot to learn. And the good news is in this election, at the end of the day, there are paper ballots and the paper ballots can be counted. And so there will be results, maybe not as quickly as we would necessarily like, but at the end of the day, there are paper ballots that will be accurate and we will get the results in due time. I think we've learned a lot in the last couple of weeks about what a mail-in election looks like. We will still have a lot more to learn about improvements to be made in the number of sites. But I think what was inspiring was to see that in the midst of a pandemic, in the midst of a very emotional time, Marylanders turned out and voted. They came out to be a part of their democratic process to express their opinions. And we need to honor that in elections, but in all parts of government with truth, with honesty, and with transparency. With that, I would like to introduce representatives from the Maryland Department of Health, who we are pleased are joining us today after several weeks of invitations. First, we have the secretary who is joining us. Do we have the secretary with us, Secretary Neal?
Yes, I'm here. Can you hear me, Mr. President?
Yes, sir. And then we have the Deputy Secretary, Dennis Schrader, and we have the Deputy Secretary, Fran Phillips of Public Health Services. Do we have our other two panelists as well?
Yes. We're both here.
Wonderful. Oh, it's all in one line. Okay, wonderful. Well, without further ado, let's go ahead and get started. Madam Speaker, does that work for you?
Yes, but I think Schrader is the Chief Operating Officer.
Oh, yes, my apologies. Yes, thank you.
Mm-hmm.
All right, Mr. Secretary.
Thank you, Mr. President, Madam Speaker, members of the task force. Thank you for having us. Since our last update to this work group, the Maryland Department of Health has been working around the clock with our state agency and local jurisdiction partners to respond to COVID-19. Come Friday, it'll be 90 days that we've been in this emergency situation, 90 days from March 5th. This is really the first lull in over 2 months where we've had a chance to talk about what amounts to a 100-year event. We're excited to share with you the work of 9,000 state and local health employees who a mere 10 weeks ago started this pandemic literally from scratch. In March, please recall Maryland's situation. In March, all of us saw locations that were overwhelmed by COVID-19, New York City, Italy, China, New Jersey. Personal protective equipment was globally unavailable. We were not able to receive adequate federal assistance, and we were competing internationally for resources. And at that time, we did not know if social distancing would work, and some of the data models suggested that we would be facing significant loss of life. Slide 3, whoever's managing the slides. I just wanted to share today, as of June 3rd, we've had nearly 55,000 positive PCR test results and a total of over 380,000 test results. Maryland has not reported serological, also known as antibody test results, in our public numbers yet. We're still trying to determine the best use for these types of tests and how to implement them with our public health colleagues from the University of Maryland School of Medicine, MedStar, and Johns Hopkins Medicine. Sadly, as of today, 2,519 Marylanders have lost their lives. As you can see from the map, the National Capital Region and the I-95 corridor counties have been the most affected by COVID-19 outbreaks. We are carefully tracking hospitalization metrics, the total number of beds, acute beds, and ICU beds. And we're also following closely testing volume and positivity rates. If you're looking at today's chart, which
2 slides.
2 slides, yeah.
2 slides forward, please.
2 slides forward, you'll see that testing volumes are up, the use of hospital beds is down, and our positivity rates have dropped, and that's a 7-day rolling average, have dropped to below 10%, to 9.5%. These are very encouraging numbers. We're hoping they get even better, but these are all very encouraging numbers. Implementing the governor's 4 building blocks to Maryland Strong Roadmap to Recovery. We're going to go over them with your permission. Expanding testing capacity, Fran's going to cover that. Establishing a robust contact tracing operation, Fran will handle that. Increased hospital surge capacity, Dennis will handle that. Ramping up the supply of PPE, Dennis will handle that. Other items that we'd like to share with you, minority health and vulnerable populations, Fran and I will do that. There's a lot of information in this update. Please get us your questions, and we'll do our best to get you the responses in writing after this work group, since we may run out of time today. Slide 5 shows the acute bed and ICU bed occupancy. As I said before, we're cautiously optimistic. You can see by the chart, all the lines are going in the right direction. And this is important. This pattern would not have been possible without the cooperation of millions of Marylanders and the governor's social distancing orders. People who stayed home to protect their neighbors. This simply would not have been possible without that kind of cooperation. The governor and his COVID-19 recovery work group have been carefully monitoring these metrics and other data to determine next steps for the Maryland Strong Roadmap to Recovery. I believe you're going to hear from Dr. Tom Inglesby of Johns Hopkins later. He's a member of that governor's work group, and I can tell you his advice and counsel has been invaluable. So we're going to go to the bed surge slide. Dennis?
Yes, sir, Mr. Secretary. If we could start on slide 9 from there. Forward the slides to slide 9. All right. We've been working with the Maryland Hospital Association and other state agencies for 3 months now, and we've also been collaborating directly with the local hospitals and the local leadership to identify approximately 6,700 beds that could address the COVID-19 surge in what we're calling Wave 1. We worked with a team of modelers to figure out what it might be, and there were both private and publicly available in order to determine early on that we needed a minimum of 6,000 beds based on the worst case that we might see, and that 25% of those would be intensive care capacity. We were able to early on establish a partnership with Johns Hopkins and the University of Maryland Medical System to create the Baltimore Convention Center Field Hospital. And while we were doing this, we were determining what the patient flow was going to be in terms of what we'd anticipated might be the flow process from observation through hospitalization, intensive care, and then convalescent. At the time, we were anticipating a length of stay of much as 12 to 15 days per patient. That too was going to create a backlog for our hospital. So one of our main goals early on was to, as we were watching Italy and New York, was not to allow our hospital system to be overrun when the surge hit. And the potential, we were also looking at ICU beds as well as ventilator usage for those ICU beds, and they were predicted by the models. We quickly reopened closed hospitals, including Laurel Medical Center in Prince George's County, and have been working to open Adventist Tacoma Park in Montgomery County, which is another. So there's 135 beds in Laurel, which includes ICU beds, and then about 200 beds in Tacoma Park. In addition to that, we have installed 50 10-bed advanced medical tents. I'll show you some pictures of those later on hospital grounds throughout the state, including 5 advanced medical tents at Jessup and 5 at Hagerstown Correctional Facilities. In addition, at Hagerstown, we have established a convalescent care operation there in the event that the volumes get larger than anticipated. And Secretary Green and the team have been working collaboratively. The goal is not to have patients coming out of the hospital requiring 2 guards each going into our hospitals. If we would reach 50 to 100, it would be quite a challenge for the hospital. So putting this capacity at Jessup and Hagerstown was a good backup plan and is now operational. We've also installed modular 8-bed intensive care units. We've ordered 8-bed intensive care units. The first 4 are installed at Adventist Fort Washington and Prince George's Hospital Center, and additional modules are currently on order. We have another 4 modules with 32 beds, and we're working with the hospitals to determine the appropriate siting. In addition, hospitals and we you'll see in a minute the structure of how all this was done. But we were working with the Hospital Association to analyze how all this ties together, and as part of that process, making sure that the Hospital Association provided us the glue that tied this process together.
Hey, Mr. Chair, can you, we have the PowerPoint. If there's any way you could kind of move it, move along, and so that we can make sure that we can hit some of the other important critical questions.
Yeah, sure. I mean, this is an incredible story of what could have been a real problem and has been a huge success story. But the challenge and the reason we're spending so much time on this is that there could be second, third, and fourth waves. And we want to make sure you understand what has come, because we're actually going to shift gears here, and I'll explain that in a minute, to how we're going to manage with the hospitals, because about half of the surge capacity came from low occupancies in the hospitals. And now that we're starting to reopen the economy and bring on elective surgeries, the hospitals will see an increase in their overall capacity, and therefore we're going to be balancing, keeping the doors open and driving and providing service to patients, while at the same time being ready for what could be, and I think Tom Inglesby will talk about this, could be a much larger second surge late summer or sometime in the fall. Anyway, so we'll be monitoring this as we go along. Slide 8, or slide 10, I think, would be on your, shows the patient surge, Unified Area Command. It shows how the state was tied together. Fran Phillips, myself, and Dr. Ted Delbridge were Unified Area Commanders. This is out of the National Incident Management System. And once FEMA took over, it became really critical for for our ability to gain access to the resources we need now and into the future to be connected through MEMA up into FEMA. And this allowed us to tie all that together. So Fran Phillips, myself, and Dr. Delbridge, and EMS, I have to emphasize, is a critical part of this, because while we are building the capacity for the hospitals, the EMS system is seeing the patient flow. And originally, the daily transport volume from the EMS system was about 1,500 patients per day. That dropped down to 700 or 800, and now it's back up to about 1,300 a day. So we're starting to see a rebound in patients. In the emergency department, we're seeing about a 35 to 45% capacity in the ED, in the emergency departments. So a lot of walk-in traffic is just starting to flow again. So anyway, we can talk more about this or answer questions, but this chart shows you the complexity of this operation across the state, and the numbers of people that were involved from the various departments and agencies. I'll jump ahead to I think I mentioned already on slide 11, the Baltimore Convention Center. I won't recover that. I mentioned Laurel, Adventist, and Hagerstown. So we can jump ahead to slide 12, if you will. I'll move this along. Slide 12 shows you the inside of one of these advanced medical tents. They're temporary structures that can hold 10 patients, and they can be deployed as either med-surg or intensive care space. They're temporary in the sense that they do not have permanent foundation with utilities, and the advanced medical tents are placed on hospital campuses to provide additional patient space without spreading staff too thin. And as I said earlier, we placed 50 of these around the state, including Montgomery County, Prince George's County, Anne Arundel County, and Baltimore City. The key to this, which I think is really critical, is that in working with the hospitals, staffing is the real issue in all of this. Physical plant, we're finding we're able to put in place, but there was a lot of work done. Brian Morose from our team set up a staffing recruitment process with the Hospital Association and one of our contractors pulled that together, and we were able to begin to recruit staffing to deploy them. So that's the biggest challenge here, if you will. But these advanced medical, and it's really critical to leverage the hospital staff as close to the hospital as possible. We examined alternative care sites in places external from the hospital, and it was very clear in talking to the hospitals that in order to leverage their very comprehensive and skilled clinical staff, the governor issued orders in order to be able to expand and extend staffing, but they have to be supervised, and we needed medical direction from the hospitals. So staying as close to the hospitals with this extra capacity was really critical. I'll go to slide 14. That gives you a picture of the advanced medical tent. As you can see, they're solid walls. They're raised and level to prevent weather from limiting their use. They have air conditioning with reverse or negative air pressure, which, because of the COVID virus, allows you to exhaust the air out of the facility. And we are working on making sure that these are properly winterized. And then on slide 15, I think that's the modular ICU. I've already talked about that. So in regular discussions with our local jurisdictions and hospitals, and we've had a round robin of discussions with local officials or emergency managers, local health officers, and the hospitals over the last 10 to 12 weeks to make sure we were coordinated with them. And as I mentioned earlier, we're very focused, particularly on Montgomery County and Prince George's County at the moment, where we still are seeing requirements for ICU capacity and med-surg capacity.
Thank you very much. And we don't want to in any way diminish the remarkable work that's happened around the surge prevention. I think that's one of the certainly the success stories, and the fact that it hasn't been used as intensely is a huge benefit to the state. So we're very, very much appreciate that. If we could kind of move us along into the next topic areas.
May we talk about PPE? That's probably one of the most important. Yeah, Dennis?
Yeah, very good. So let's jump ahead to personal protective equipment. So this was one of the really difficult problems because staff needed assurances that they could be protected while providing the direct care. Greg Todd, who's our Deputy Secretary for Operations, has been working with his team at our warehouses. We've been receiving extraordinary amounts of material. In your slides, you'll see on page slide 20, we've gotten over 6.4 million N95 respirators, 8.7 KN95, 23 million surgical masks. The one area that we are continuing to drive is the gowns. The infectious nature of this disease puts the staff in a situation where they're continuously changing gowns. So you're seeing a tenfold use of gowns from normal operations. So we've been working across the world finding gowns, and we're working very closely with the supply chain leaders from the hospitals to make sure that we understand their requirements and the state of their supply chain activities. On 21, you'll see the personal protective equipment that's been distributed to the local health officers. The local health officers are really the linchpin across the state for distribution of PPE. MEMA has a system, as you all know, called WebEOC. Requirements are fed into that system, and that goes to the managers at the warehouse, who then distribute that to the local health officers. But you can see millions of pieces of PPE have been distributed across the state. I'll also mention that we are using a Battelle decontamination system for N95 masks. We've recycled about 51,000 plus, and MedStar has been the largest user of that at the Port of Baltimore. So there's a great deal going on with PPE. We're starting to see a critical flow after many weeks of that process working very hard. There's one other slide that I'll leave to you. It gives you an idea of the burn rates for PPE, for the EMS system, for hospitals, long-term care, through Fran's efforts with the teams. We have been supporting the nursing homes and getting them the PPE. That's infection control at this level is not their normal course of business. So it's been really critical that the state has been supporting the nursing homes in that area. And then the chart on the left of slide 22 shows you the volumes of what's been received and what's been distributed. So I'll stop there, Mr. President, and turn it back to Secretary Neal.
Thank you. We'll do questions after all of the members of the Department of Health have presented. And thank you very much for that part.
Yes, sir. We're now going to talk about expanding testing capacity. Fran.
Thank you, Mr. Secretary. Mr. President, Madam Speaker, and members of the work group, thank you for having us. It is speaking for public health, both state and local public health departments. It's an honor, it's a privilege, and it is unprecedented to serve Marylanders at this moment. This is for those of us who spent a career in public health. This is the kind of sort of unimaginable circumstance that we've been trained in. We considered at some point that it could be hypotheticals to be talking about measures such as social distancing, such as the calculation of positivity and burn rates and the like. And so here we are. And I just have to say, on behalf of my colleagues, I couldn't be prouder of the team that has served Maryland for the last 100 and some odd days, both at the state health department and in local health departments. So that's our EPI people, state and local, who are monitoring all the data. That's all the infection control specialists, our laboratory, our testing team, contact tracing. The local health departments have been just tremendous partners to communities, to business, to elected officials with outbreak control, with PPE distribution, all of the disease investigations, testing, and guidance. Guidance now as we cautiously step forward to reopening, and guidance to child care and businesses and the like. So this is a moment, certainly in our careers, and I'm just so proud of where we've come from. And we know we're not done yet. As Dennis said, we are looking perhaps at the end of the first wave. We are in a bit of a lull right now. As the Secretary said, our numbers are encouraging right now. We know that there's not a vaccine on the horizon anytime soon, and we know that continued vulnerability of Marylanders, the vulnerability to this deadly and highly transmissible virus, will be with us for months and months to come. So what I'm going to talk about in terms of testing capacity and contact tracing, this is not once and done. We are digging in now for a very long campaign in both of those efforts, and really want to thank our partners across state government for bringing the kinds of support that I'll mention in a moment. So as the governor has laid out, we have a series of goals to achieve in terms of overall testing across the state every day. That's 10,000 PCR, and I'll talk a little bit in a minute about that, but PCR tests, 10,000 a day. We are reaching that most days now. We want to sustain that and bring that up to the next goal, reaching 20,000 tests a day. Testing is one of the four cornerstones, building blocks of reopening, and along those lines, you can see a number of approaches. So we don't just certainly count the volume of testing that we are able to produce every day in our state lab, which has ramped up considerably. We're looking across all of the labs that are available to Marylanders, whether that's in the commercial labs, the high volume interstate commercial labs, our terrific academic partner that I will talk about, but also looking at other kinds of partnerships. For example, retailers, retail pharmacies now. I think you know that CVS has now opened up a second round of drive-throughs, and however Marylanders find it convenient to get a test at the moment that they believe they need a test, or the moment that their provider believes they need a test, that is our goal, to make that as accessible as possible. So we'll talk about. I do want to talk a little bit about testing, because I can tell you I've learned more about testing and laboratory work than I ever had in my entire career, and it's confusing. So if we can go to the next slide, I just want to show you a couple of photographs of what this looks like. For some of you, I think, may have already been tested, and you've had experience with some of these devices, but I think it's helpful to actually see a visual of what we're talking about when we talk about swabs and kits and the like. So the next slide shows you on the left. This is actually the swab is on the left-hand side. That's a very long Q-tip-like looking device that goes into the back of an individual's nose or throat to really to collect the specimen. That specimen, that swab, goes into that tube, and that tube is what's called the viral transport media. These have been you may have heard of these terms because they were such incredible international shortages of these supplies, and these are critical to actually obtain the specimen from the individual. Those two pieces of equipment are together. In the middle photograph you see is what's called specimen collection kit. And so there's this word kit has been used for a lot of different components, and I wanted to make it clear that specimen collection kit is nothing more than that swab and that tube in which it may be normal saline, maybe salt water, or whatever the material is to preserve that specimen is sent to the lab along with the paperwork that you can see. And on the right-hand side, you can see this is, for example, at the Timonium Fairgrounds. This was one of the drive-through. So this is a specimen collection site, and folks there are fully dressed in PPE as they need to in order to do that kind of specimen collection. So my last slide for Testing 101, and again, this is a little busy one, but I'm going to break it down into three components. And it's very, very important to understand that in order for a specimen to be collected from the back of your throat and then 24 or 48 hours later get your test result, there are a number of components that need to come together in order to make that test result successful. And so the first type that we just went through the first type of components are the specimen collection kits. So in terms of swabs and the viral transport medium, both in our state lab and finally in other labs across the state, what had been a tremendous shortage of these two critical supplies, global shortage, is now easing, and so that we are getting supplies through our commercial supply chain as well as through some federal allotments of much more access to these swabs and to the viral transport medium than we ever have had in the past several months. The middle section here, so if you think of these three components, the first is collecting the specimen. The middle section is the first thing that happens once the specimen arrives in the lab. And what has to happen is that the viral material that's on the end of that swab needs to be pulled out of that swab, literally pulled out, and that extracted RNA, the pieces, the fragments out of the virus, which is the actual footprint of that virus, needs to be extracted out of the slide, and to do so requires a very special chemical. And that's something called a reagent, an extraction reagent. Again, an incredible shortage of this particular component in every single lab across the country in March and in April, and lessening up now. So you may have heard the term reagent or extraction reagent. That's that middle component that's necessary to pull the virus out of the swab and actually put it in a usable form that's subject to testing. And then the third step in the process is when that extracted RNA fragment is amplified. In other words, it's reproduced, it's made larger, and it is put through a chemical assay, a chemical test, on a machine, a high volume machine. You can think of it as muffin tins. So 96 muffin tins at a time, and these high volume platforms can run these tests if they have the right assay, the right chemical mix at the conclusion of this process in order to produce the PCR chain. So really it's three components or three stages, each of which has a critical component that was quite a shortage. So we're now seeing loosening up of that, and if we go to the next slide, you'll see how we are increasing the capacity every day. Today was a phenomenal day in terms of number of cases. In terms of number of test results reported in the last 24 hours. We had 14,385 tests, well over that 10,000 goal. Those tests were reported in the last 24 hours, and that's indicative of the increased volume in our state public health lab, as well as with our partners. These are contractual partnerships that we have with 3 national commercial labs, that's LabCorp, Quest, and Mako, high volume, out-of-state labs, and 3 very important in-state labs, ICMD in Greenbelt and Scion in Frederick. So the combination of those labs are making a huge difference in terms of our volume. But what I think is so important as we look forward to the fall, I suppose, look forward with some trepidation, I'll have to say, is that what we learned in the last 90 days is that we were on our own. We were on our own for testing, for PPE. We needed to develop supply chains to bring home to Maryland the critical equipment that we needed. And that was made crystal clear with all of the shortages around testing. What we have been able to develop in Maryland is a cornerstone of resiliency. We have a partnership now with UMB, with University of Maryland, Baltimore. University of Maryland, Baltimore has an international reputation for biomedicine. The leadership at the school, working with our leadership here, turned to the University of Maryland, Baltimore's Institute for Genome Sciences and essentially unleashed the capacity of that research lab to turn it over to do clinical work on behalf of Marylanders. And so this is so hugely important because this is our state asset. This gives us homegrown resilience so that we are not dependent, as helpful as these out-of-state commercial labs have been, we are not dependent on them. We have this asset, which is really the signature lab in Maryland, can now do business on behalf of Marylanders throughout the course of this pandemic. So that's just a tremendously important and valuable partnership. Moving on to, again, some of what you know as far as the testing that's gone on around our state. We distribute the specimen collection kits, right? So we don't distribute those back-end lab chemicals, the PCR assays, sometimes also called test kits. So this is where it's a little confusing. The test kits stay in the lab. That's what actually runs the lab process itself. What gets distributed out to local health departments and is in play in all of our VEEP and other testing sites are the specimen collection kits. So speaking of vehicle emissions inspection programs, we do have we have VEEP sites in place. We've got the opportunity now to grow 4 regional sites. We've found tremendous turnout for our sites when we are able to provide them without appointment, without the need for a prior physician order. So that is the model in place right now. In fact, today, Wednesday and Fridays at Six Flags in Prince George's County. All-time high in terms of number of people tested, and that's the kind of access and response that we look forward to establishing around the state. Mentioned universal testing that's been underway, now concluded actually in nursing homes across the state, and now we are turning to a very similar kind of initiative with all of the state's correctional facilities, both the inmates as well as staff, for adults and also for Department of Juvenile Services. The next slide shows is a breakdown, as I mentioned, of the VEEP sites where they were last week. These are the state-operated sites. Hospitals, health systems, local health departments, and others, CVS, for example, Walmart, have other test sites now in the community. But just to look at the numbers for our sites for last week. As you can see, Six Flags was 1,686 tests yesterday. I'm sorry, that was Friday. And we're expecting to beat that today and again on Friday as we open up more and more test sites. So we are, next slide, as the Secretary said, we are seeing two very positive indicators moving in the right direction, and that's overall testing volume is up, significantly up in the last 30 days, and so is our positivity rate is down. So positivity has declined now under 10%, 9.5% today from what was a high middle of April. Looks like it was about April 16th where we were well over 25%. And so that's very encouraging. That's not to say that there isn't COVID virus out there. It absolutely is out there. But what we're seeing is the rate of positivity is coming down as we are increasing the access to testing. I mentioned, on the next slide, I mentioned nursing homes. Governor Hogan issued an order to address what we had seen was a terribly, terribly troubling, very tragic series of outbreaks in nursing homes here in Maryland, like we've seen in other states. And so initially, we were the first state to organize under the governor's order strike teams. That sounds kind of offensive. It was not offensive. Strike teams are very specialized teams of the medic team from the National Guard, as well as the federal DMAT teams, disaster medical assistance teams, very specialized physicians, nurses, medics, who could come in and offer assistance. This was optional, it was voluntary, and to come in and to provide infection control assistance, to provide PPE to nursing homes, and to really look at the practices and to provide advice on to how to interrupt transmission. In addition to the universal testing and the strike teams, we also now have something called bridge teams. And this is why this is important. When we went into nursing homes working with the National Guard and distributed thousands and thousands of test kits, we anticipated that we would find asymptomatic staff people. Now remember, these nursing homes have been essentially isolated, no visitors, very, very restricted access to vendors and anyone else. So it was really the staff coming and going who unwittingly would bring in virus. They were asymptomatic, they had been screened, but they brought virus into these nursing homes with very vulnerable people. So the approach to that is to do universal testing, test everyone at the same time, all the staff as well as residents, and then to come back serially and retest staff as needed. We knew that we would find staff that were asymptomatic that would need to be sent home for their period of isolation, and in so doing create absenteeism. Really big problem to begin with nursing homes. And so the bridge teams were a way to offer nursing home staff coverage for up to 96 hours in crisis situations. And it's tremendously useful, tremendously successful, and kind of brought us over that bridge as we have now completed the distribution to all 227 nursing homes of all of the test kits for them, the specimen collection kits for them to distribute, to collect those specimens, and all of those specimens will be returned to the state lab no later than Friday. So moving, I guess, to another set of data. I mentioned lots of the collection kits. It's actually 55,001 were distributed by our National Guard partners in a tremendous effort, and have been, I think, roundly appreciated by the nursing home industry as one that we now see a continual decline, an overall decline in our state's deaths. And where at one point nursing homes were fueling over 50% of our deaths. If you look at the trend line, you'll see almost a bell curve as to how our deaths now have come down from a peak as they were about 6 weeks ago.
And Madam Deputy Secretary, those 55,000, is that 55,000 of the 500,000?
That's 55,001 actually specimen collection kits that have been distributed to nursing homes.
Of the 500,000 that were acquired?
We have the there is no limit to how many test kits have been acquired. So there are, through the various supply channels that I mentioned, through LabCorp, through the commercial vendors, as well as through the other labs. So we've got every day thousands and thousands of collection kits that we're using.
Okay. And we're on contact tracing now, I believe.
Yes, sir. Yes. And contact tracing is, here we are. We have no vaccine. We have one way to suppress the transmission of this virus, and that way is to act early. It's a race against time. When an individual tests positive, to contact that individual to make sure that that person can stay safely in isolation through the duration of the period that they are infectious, to interview that person to see who else would have been close contacts, and to likewise develop a network of either isolation or quarantine so as to interrupt transmission. That's what we have to do. And so while that's sort of bread and butter public health on a much lower scale in terms of looking at infectious tuberculosis patients, for example, we have hugely ramped up in local health departments and through a statewide initiative our ability to do contact tracing for up to 1,000 new cases a day and 10,000 contacts every day to make sure that we have a handle on new cases and we can quickly interrupt and suppress transmission. So we've got really a very unique system of integrating an electronic platform so that if a contact lives in Baltimore City but has contacts who live on the Eastern Shore and another who lives in Prince George's County, those local health departments, as well as the state investigators, are all operating off the same platform so that people are not lost in handoffs, for example, and so that we can do this in a way that really has been a model for the rest of the country. I know Delaware and several other states are flat out adopting our approach. And if they are not adopting our approach, certainly our neighbors in Virginia and DC are working very closely to mimic it in their own jurisdictions. Just to say that contact tracing may be a little strange for the person who's contacted, and so we are working with some public messaging for folks to understand what it is, why it's helpful to respond, why responding to a call will be secure, and while doing so will really help our entire community recover. So we want to make clear to folks what will not happen ever in a contact tracing call, and that's to reveal any kind of Social Security, other kinds of financial information, but to emphasize that the information that is shared is protected, it is secure, and the individual who's contacted that name will not be used in further follow-up investigations with contacts. We are also very attuned to the fact that some people will not be able to be reached by phone. They may not speak English. They may have difficulties maintaining isolation because of their housing or other situations. And that's where, again, local health departments are so important to do the on-the-ground community health worker type, high touch and low tech kind of community-based contact tracing that they're all engaged in doing. And so with that, I think we'll move into Secretary's indicating that I should continue on to finish up and very quickly, and happy to take your questions. Minority disparities has been a tremendous concern as far as the disproportionate impact of this virus on our communities of color, on people who are low income, on people who have underlying medical conditions. And so we see that in terms of the disparities of the cases, but most pronounced disparities amongst racial and ethnic groups with regard to deaths. And so how can we leverage what we have learned in other kinds of chronic disease settings, and how can we leverage that partnerships and knowledge to really bring much greater protections to our minority communities who are particularly hardest hit? I will say that we've had the experience on the Eastern Shore with the Eastern Shore poultry workers, that the experience there was very unique and challenging in terms of language and cultural issues. We were able to breach that challenge by turning to local churches, local community organizations, and it certainly doesn't work from top down. It all depends on having the kinds of local contacts that can be successful. So using that experience, we're now moving to the other side of the Bay and looking to work with several of the large jurisdictions that have minority communities, but also that have significant amounts of cases of virus, and working with them in their communities so that they can have an opportunity to intervene in a much more community-focused way and build on their strengths. So the opportunity, lastly, to talk about vulnerable populations. We're all in this together, but some of us have greater risk, and some of us have more serious consequences. And so it is not one size fits all. We're looking at ways that we can develop teams and continue to work with local health departments and community organizations on particularly serving the needs of vulnerable groups, whether that's PPE needs for community organizations or heightened testing or other kinds of guidance. The last thing I'll just close out with is remdesivir. Remdesivir is an antiviral drug that has been shown in an initial clinical trial by the FDA to be helpful for people with serious illness, as hospitalized people, helpful in terms of shortening their recovery time. We are receiving shipments now from the federal government of donated medication. We are keeping that in cold storage and very, very promptly then turning that medication around. It's an IV medication, it needs to be refrigerated, needs to be frozen. We're turning that around to hospitals across the state according to an allocation formula based on their hospitalized COVID patients. And so we have sent out 2 shipments, and I believe we're in line to receive another one today, or this week, I should say, this week. So working closely with the hospitals individually, as well as the hospital associations on that allocation. So with that, Mr. Secretary and Mr. President, Madam Speaker, that concludes our formal presentation. And thank you very much. Again, thank you so much for your support, for your interest and attention. I'm happy to take questions.
Well, thank you for the information from all members of the Department of Health. We have several questions from members. Let's begin with Senator Lamb.
Thank you, President Ferguson. I wanted to dive a little bit more deeply into the tests. So I think, Deputy Secretary, you mentioned that there are 10,000 tests that are being run a day, and that's the state's goal. But my understanding is that that goal includes all tests in the state. That includes tests that are run here, for example, at Johns Hopkins, where I'm at UMS, at MedStar, LabCorp, Quest. That is an overall cumulative total, right? And so my question, because it particularly pertains to the 500,000 tests that were South Korean tests that were procured and also had a press conference and photo op at BWI with great fanfare. How many of those tests that are being done daily, how many of those 10,000 tests that are being done daily are South Korean tests? And how many total South Korean tests have been used to date of that 500,000?
So thank you, Senator Lamb, and you're absolutely right that the goals that I reported are goals for all coming out of all labs, including hospital labs, the commercial labs, CVS, and the state labs. And so the goal here is to have testing readily available to Marylanders, and to make that obviously high quality PCR testing, and that is exactly the goal that has been accomplished. So the goal has been accomplished through a combination of the source, the particular source of the test assays, and some of those have included various suppliers that for months we hustled and were able to secure under contract. And,
all due respect, how many, it's a very simple question, how many of those tests have been used today?
So the tests that have been used have been part, in terms of the South Korean tests, That is part of a very long-term strategy.
Can you give us a number?
I can't, Senator, give you a number right now as far as how many of those have been used. Those tests have been fully validated. Those tests have been secured as really the key resource for the University of Maryland, Baltimore lab. This is, again, a step towards self-sufficiency, to our resilience. So we have the ability, without having to have dependence on outside labs, we have the ability now to turn out high-quality, fully validated tests on behalf of Marylanders as we look forward, as you know, to the fall. And the fall is a period that we're looking to, as I said, with some trepidation, part of the governor's long-term strategy. It is not quick. We are looking to a situation where we may have confounding seasonal influenza, where we may have more reopening, where we have much greater demand on our testing capability. And so part of that...
And I share that concern too. I think that's why we wanted to drill down on these tests a little bit more. Last week, we had a hearing with DGS in the Senate Education, Health, Environmental Affairs Committee. And what DGS conveyed to us is that we should check with you on the status of needed supplies for these South Korean tests. Now, what you just went over pointed out that, in my interpretation, you're missing extraction reagent, which according to the application that was submitted to FDA, the reaction reagent are some type of chemicals from QIAGEN. That's the recommended type of chemical to be able to pull the RNA off the swab. If you go to the QIAGEN website right now and look up the catalog number for that, it says that you can buy a kit of 250 reagent extraction kits for $1,200. So if you were to actually purchase that full amount that's needed for the 500,000 South Korean tests, that comes to be about $2.4 million in additional extraction reagents that are needed. Is that what you're looking to procure at this time? And if so, why is DGS not aware of this procurement request?
So, Senator, we have no difficulty with matching up the required reagent necessary to run that particular assay, and that's a very.
Why are we not running the tests more quickly?
So, Senator, that is exactly what the University of Maryland, Baltimore is setting about to do. You know, that had been.
Are we missing the laboratory equipment then? Is that the other piece that we're missing?
Oh, Senator, we're not missing any component that's necessary to operate these tests. The University of Maryland, Baltimore has fully installed high volume equipment. The platform is there, the swabs are there, the VTM is there, the reagent is there. So what has been assembled now in Maryland's signature lab are the components necessary to sustain Maryland through what we're seeing ahead as can be a very rocky period if we look into the fall. So we're using that judiciously as part of a long-term strategy. Meanwhile, we are maximizing our available contracts right now for these out-of-state labs. For as long as they're good, we're going to use them, and we're going to use them in deep sites and everywhere else. But we have what I kind of call the jewel in the crown as far as this unique state capability at University of Maryland, Baltimore, with those very innovative acquired kits, those test assay available throughout, and the whole spectrum of components necessary to run those tests available to Maryland.
So
Thank you. One last question just to follow up on that, if I may. Very briefly. So, you know, something here doesn't compute because it seems like you say all the pieces, but we're not testing to the degree that we really ought to. Because in slide 31, you said that there was an executive order issued in April to test all nursing sites. And the specimen collection kits, however, won't be collected until June 5th. That's 2 months later. So if we have 500,000 tests that are in hand here in the state, and we've identified a priority for strike teams to go into nursing homes, why is it taking 2 months for the specimen collection kits to get out there and make it back? And we haven't tested all those kits yet.
Senator, there was no shortage of test kits to distribute to the nursing homes. And I have tremendous respect for the National Guard. We have 227 nursing homes. And what they did initially was to go out and contact every single one of them, put them through the paces of what universal testing was, and then to deliver to every one of them in sequence test kits, specimen collection kits. That is no mean feat, Then the clinical staff and the nursing homes, it is up to them to actually do the specimen collection on the residents as well as on themselves. Staff in nursing homes, as you know, rotate. They have shifts. Some people are weekend, so that if the collection kits are delivered, there is a delay. There is absolutely a delay in getting all of those specimens sent to the lab. But that's not because of a problem with the capacity of the labs. That's because of the natural turnover and the staffing in nursing homes. So it has been several weeks, and the last tests will be submitted of all 55,001 will be submitted to the lab no later than this Friday.
Madam Speaker, I believe there's some.
Yes, Majority Leader.
Thank you, Madam Speaker. Thank you for the presentation. My question has to do with the expansion of testing to the general public and folks that are asymptomatic at these new testing sites. Where are those testing sites currently located where the general public can access them? I know I've heard of Six Flags, I've heard of Timonium, and why was the decision made to expand testing to the general public at that point in time, given that I've still heard from some of my senior facilities, not necessarily nursing homes, but senior living facilities in the district, that they haven't been able to get tests for all of their residents?
All right, so thank you for that. The CDC expanded the criteria for testing 3 or 4 weeks ago. We all remember it had been very stringent criteria for people that had very severe or moderate symptoms, and much of that was changed. Well, that was changed to include people that do not have symptoms, that people who are recommended either by their provider or by their health department to get tested regardless of symptoms. The reason that stringent criteria was expanded was twofold. The testing, the capability definitely was expanded nationally. And secondly, the science caught up with what had been the criteria. The science meaning that, I guess in March, it was thought to be the fact that people could not shed virus until they had symptoms. What has been proven since then is, in fact, up to 2 days before the development of symptoms, people are actually infectious. And so that's where the opportunity to test people who don't have symptoms yet, but who have some concern about possible exposure, people whose work puts them in contact as essential workers with high numbers of people. That is where CDC came around and said, we need to open this up and to allow asymptomatic people to be tested. So that's when our guidance changed as far as the location of the testing centers. There's some of them were presented on that slide. On the department's website, we have a Find a Test feature that is scores and scores of test sites around the state with contact information. Some of them have, they have different hours, but this is an ever-expanding series network of testing capacities.
Okay, but so my question is about also locations, because at least in the public announcements, what's been talked about heavily in the press, the first big site that opened up was, I believe, in Baltimore County, even though Prince George's and Montgomery counties have been the largest hotspots in the state. So why was the decision made to open up testing there? It seems a little odd, especially given that at the same time that was happening, the administration was starting to talk more extensively about positivity rates, and there's to adjust the positivity rate, one of which is just to increase the denominator significantly and start testing a lot more people. So why Baltimore County when the hotspots have been in the DC area?
Right, thank you. And you're right, hotspots have been Montgomery and Prince George's County, which is why the very first mass drive-through was located at FedEx Field with tremendous support from the Prince George's County Health Department. Prince George's County Health Department set that up. The state brought in the test equipment, and the National Guard set up that site. It was a site that proved not particularly conducive to March winds, and so it was moved at the request of Prince George's County Health Department to the Cheverly location, where it continues today. We know that there was a need for more testing in Prince George's County. That's why initially the the Hyattsville Veep site was opened up. That could not accommodate what we wanted to see as far as expanded capacity. So thanks to the Six Flags owner, we opened that up, as well as a Veep site in Clinton. In Montgomery County, working with that health department, we've had a White Oak, very, very steady and very successful testing in White Oak, as well as many of the hospitals in Montgomery County have also set up drive-throughs on their parking lot. So we've actually taken our capabilities working with every single health department that's available. Timonium Fairgrounds in Baltimore County is another high volume in terms of lots of driveways and access for vehicles location. Baltimore County was very pleased to partner with us. And so that was another opportunity. Carroll County, we've got Carroll County Ag Center. We're looking at that as well as other locations in Baltimore City, Mondawmin Mall and Druid. So we've got just a lot of opportunities. In addition, I will say to these dedicated sites, every week the state sends to every health department, every local health department, a weekly allocation of specimen collection kits for them to use in creative ways, whether that's through mobile testing that the local health department puts together, through community health centers. We send anywhere from 2,000 a week to 100 a week, depending on what the county asks. And any county that asks for more gets more. So we're really relying on our local partners to figure out other creative ways to get the testing done.
Senator Roosevelt.
Thank you very much. I got a couple of questions back to testing. One is, your goal is 20,000 a day. If I got the math right, that works out to about 2% of the state population. That would mean that basically puts you on the low end of the ranges that at least I've been hearing from all the public health experts of the breadth of testing we need. Is your limited goal on testing related to demand or supply? Do you not think we need to do more testing than that? Or do you think we just can't get the supplies?
Well, I think this, thank you for that question, Senator, and it's a really good one. What we're hearing from employers, large employers, small employers, as they move very cautiously to reopening, is they want to make sure that they can say that their work site is safe. They can say that to their customers, that their retail space is safe. And so to do that, retailers and businesses are looking for testing. Really, they're not looking for the kind of testing we're talking about here. They're not looking for a test that goes out to a lab, and that even though Maryland's median turnaround time is under 2 days, which is great, that's not what the retailers are looking for. And the business of test development now, the manufacturers know that and are working to develop much more accurate and lower cost point of care testing, so that that has got to be part of the future equation, not just test results that come from a lab, but what can be administered on site, so that we can have a different kind of world. It'll be a new normal as far as reopening. So those kinds of tests are also included in this goal of 20,000 tests a day.
Well, that's included. So that's what my point is. So your 2% goal includes all of that as well. And I'm asking you, why is your goal so low?
Right now, 10% of the population a month.
I'm sorry. So if we're talking about a goal of 20,000 tests a day,
right?
And so we feel that that is a robust goal for the state. And I guess today we're 14,000 now. We want to sustain that and to make that capability available, and also to encourage new testing devices, new technology, and we know that they're on the horizon. We know that those are in the development stage as well as the validation stage, I should say, with FDA.
Thank you, Mr. President. I would hope that we could do a follow-up to the department, asking them for some detail of why they've set the goal where they've set it. It seems very low in relation to what I've been reading and hearing from public health officials. So it'd be good to get an explanation for that after the meeting. I have one more question for right now.
Very, very briefly, Senator.
It'll be very briefly. As we've seen on this call, I see it with my constituents. There's enormous confusion about who should get tested. There was a story in the Washington Post over the weekend saying that fewer people are getting tested, then they have tests in DC because everybody's so confused about it. Are you saying that today the policy of the state of Maryland is testing on demand, that if someone needs a test or someone thinks they need a test, they should be able to get a test?
That's right. That's right. And I feel that we've put out guidance to providers. We've done so in a number of ways, including through CRISP, which is the Health Information Exchange, which is the platform on which providers actually order tests. We've clarified that, consistent with the CDC guidance, one doesn't need to wait. A provider doesn't need to wait for an individual to come in with symptoms. If a person comes in and says, I think I've had contact with someone, I'm worried about, I had a long trip on Metro, I commute back and forth, I have a service industry or a food service job where I'm in contact with, whatever the reason is, there's not a reason to be stingy with tests anymore. That's a very important message, I think.
Okay. Vice Chair Jackson.
Thank you, Madam Speaker, and thank you for the presentation. A couple of very short questions. First, who's leading the test sites? Is that the locals regarding policy, staffing, in particular volunteers, because of possible surges capacity-wise, and supplies? That's the first question.
So, sir, the test sites are, some of them are state operated, some of them are operated by local health departments. Some test sites are operated by health systems, whether that's hospitals or, for example, LifeBridge or whatnot. So it's kind of a mixed bag in terms of who's operating, who's staffing those test sites. And,
okay, so who is to ensure? I mean, does the state have any oversight regarding capacity to ensure that we're going to be able to sustain these, either volunteer staffing or others? Or is that left up to the locals or the individuals?
The staff actually that you see at the test sites generally are, setting aside the National Guard because they've been tremendously helpful with logistics and traffic control. But the clinical staff are generally individuals who are local health department employees, or they are contractual employees contracted by either the state or the local health department. And here's something really interesting that I think relates to how far we've come in the last 90 days. We worked really closely with MIMS, the state EMS group, on looking to see how we could expand a pool of, not volunteers, a pool of vetted clinical students. These are medical students, nursing students who are very close to the end of their education, but who would be available to work, we had thought at that time, in surge capacity, perhaps in some of the facilities that Dennis Schrader spoke about. We got these students fully vetted and trained and uploaded into a registry. Fortunately, we haven't had to use them for medical care, but this is a pool of, we call them externs, that we are now drawing from to staff the test sites, and they are thrilled to do so. And so they work under the supervision of RNs and other licensed clinicians. But this is a way to bring real-world experience to these students in a way that will be sustained. I know, having spoken with the leadership at University of Maryland on their part, will be sustaining those students to continue that kind of testing work under supervision as the university reopens.
All right, thank you. Madam Speaker, very briefly, a second question. Sort of a follow-up to the majority leader's question. You spoke at the end of your presentation about a two-phased approach. You were starting with the plants on the Eastern Shore, and then your second phase included Anne Arundel, Prince George's, Baltimore City, County, where the heart of the cases are. So why second phase with us or with those jurisdictions versus, in the smaller jurisdictions? Particularly when you all are preparing for a possible surge. That's it, Madam Speaker. Thank you.
Next up, I believe we have Senator Hershey.
Thank you very much, Mr. President. Deputy Secretary Phillips, thanks so much for your comments. If I could just go back to contact tracing a little bit. A couple fairly simple questions, but maybe they'll just help us with some clarification as we communicate back with our constituents. But the words isolation and quarantine have been used. Are they interchangeable, or could you please define them? Second, you had spoken that there could be a phone call during the contact tracing process in which guidance was provided. I was wondering if you could briefly describe what that guidance is and let us know if either isolation or quarantine is mandatory or enforceable. And then finally, somewhat unfortunately, I think we've used federal guidelines in how we've defined workers as either essential or non-essential. Would the guidance in the contact tracing process change based on someone's work classification? Thanks.
No, thank you, Senator. You raise a really important question, isolation versus quarantine. And either way, it means people need to stay away from other people so as not to be exposed, not to inadvertently expose people. Isolation is the term that's used for people who have been confirmed, that have confirmed disease and that are what we call a case, a confirmed case. Quarantine is the term to have people remain at home, people who have been contacts, who have not been confirmed, but who have been close contacts with a confirmed case. So that's a bit of semantics, and you're right, people, including myself, have used it kind of interchangeably, but the strict definition is a little bit different depending on who the individual is. You asked about the guidance that's given in contact tracing, and it's very extensive, actually. It starts off with understanding speaking with a case, who may have just now received the news that they are positive, or maybe they have known that for some time, but to understand what their physical condition is. How serious is their illness? Are they having any kind of symptoms that would suggest a need for immediate care? So ruling that out then, understanding that person's ability to maintain isolation, whether they have adequate separation in terms of their housing, adequate supports for their groceries, their pharmacy, childcare. What are any barriers to their remaining in isolation? Then comes the part of the question, the interview process about other kinds of other contacts, and that people are asked to go through their past calendar, and it can be quite an extensive interview to try to elicit where they were and who they were with, how close in terms of physical distance for what period of time. The individual is asked whether they would like to have, they will have continued contact with the contact tracer during the course of their isolation. So they're asked if they would like to do that via more phone calls, via text, via email, and if their situation changes, to make sure that they connect back with the contact tracer so that they can get assistance as needed. So it's that kind of very specialized guidance about the individual person's case and their situation. We do check back in, as I said, with individuals who are either in isolation or quarantine, and make sure that they are complying, that they're able to comply, and that they do comply. We have not had problems other than I can count on fewer than fingers on one hand of instances of people anywhere in the state who have willfully violated either isolation or quarantine, and we have found that in those cases, individuals have been guided back into their homes or into alternative quarantine facilities that are operated by local health departments. They have been able to do so successfully, and so we have not seen a need for any more firm enforcement of isolation or quarantine. Although we would have, the local health officer has the authority to do so if that's necessary. I don't know about your last.
Essential versus non-essential.
Oh, right. So yes, U.S. Department of Homeland Security has issued, they put out this list of essential industries, And I think it was just revised a little bit a week or so ago. But that is, we don't, because someone works in an essential, has an essential employer, that doesn't mean that they have therefore a free pass, so to speak, to disregard guidance on isolation or quarantine. It makes it a lot tougher, and we certainly know from nursing home experience when we ask people, staff who are asymptomatic and positive, to get into isolation and to remain so. We help them with that. We help the individuals with that, but we've come to find out that we absolutely need to help the employer as well.
Speaker Pro Tem Sample Hughes.
Thank you, Madam Speaker. And my question is regarding what type of coverage has been provided for the shelters. I've had numerous persons contact me about getting shelters, but what we've had to do on the Eastern Shore in particular is to close down some of those shelters because they didn't have the proper PPEs nor the ability to test on site. Now, I have worked with the local health officer, but I don't feel like I'm getting anywhere with that. So I just need to know what level of support are we providing statewide to our homeless shelters?
Yeah, so we know that people that are in congregate living are particularly vulnerable, whether that's in shelters, in detention centers, or nursing homes, in fact. Through again, local health departments or local emergency managers, that is the conduit for support, particularly for PPE. And shelters, congregate living organizations are absolutely on the PPE list in terms of eligibility for distributing necessary equipment and supplies. So I know that many health departments have worked really closely with shelters, not only on PPE, but also on infection control, on testing. And so I would just really direct the shelters to be in touch either with their health officer or their local emergency manager.
But you're missing the point. I've worked with the local health departments, and in particular, they're not providing guidance on the testing. What are we doing for the testing of shelters? Or what guidance are you providing the health departments?
I apologize, I misunderstood. I thought the question was about PPE. But on testing, again, I mentioned that health departments are getting weekly allotments of tests, of the ability to go out and to collect specimens. And I personally speak 3 times a week with health officers, Monday, Wednesday, and Friday. And we have an hour-long conference call on many, many subjects, as you can imagine. Prioritization of testing is always has been a local issue, a local struggle. But again, that is really easing up. And so if there is a need for testing in a shelter, that shelter organization should be contacting the local health department. Local health department, if the local health department needs more test collection kits, we will supply that to them, much as we have done with PPE now. And I'm really happy to say that, we've come a long way in being able to do that. And so here we are. So I'm very pleased with that.
And lastly, who's going to bear the cost? Would that be the health department's expense for the shelter, or should the shelter incur the cost?
No. That's completely covered by the state. There is no cost to the shelter. There is no cost to the local health department, just as with PPE. Absolutely none.
Thank you.
I believe the last Senate question we have is from Chairwoman Kelly. One second, Madam Chair. I think we have to unmute you.
We're running into some technical issues there.
Let me see if I can do it. No. It does not appear. Madam Chair, we're gonna have one more question. If the House could go, and then we'll come right back and see if we can figure this out.
Sure. Yeah. Vice Chair Pena-Melman. Says unmute herself.
Good morning. Can you hear me?
Yes.
Thank you so much to everyone. Good morning, Madam Speaker. I have a couple of questions, and then I'll I'll mute myself. First of all, thank you so much for the presentation today. One first question is, why are we not increasing Medicaid reimbursements in nursing homes when other states are doing it? The problem is that, a lot of them will go out of business, and we cannot afford that. The second question I have is regarding the 500,000 tests. Can you give us a list offline about how many of those went to the nursing homes? How many of those tests have gone to the local health department or anywhere else? The third question I have is regarding the Office of Minority Health. Are we going to give that office some teeth? Because that office has lost pins in the past. Are we going to start, sharing the data from Medicaid with that office? What is the plan? Because that is a really important issue. And then lastly, regarding contact tracing, can you give us a breakdown offline of the ethnic breakdown? How many African Americans have you hired? How many Latinos or others? And finally, regarding the zip code 20783, which has the highest number of COVID-19 cases in our state, which is the immigrant Latino community, are you going to open another facility? You opened Titusville, which was mentioned, and then you closed it. And are you going to have a public health messaging in Spanish? We know there's no vaccine. Are you going to start taking ads? What is the work you're doing in that community? Thank you very much, Madam Speaker.
So thank you. I can start with some of your questions in terms of Medicaid reimbursement. I'm not certain that I can answer that. But in terms of the nursing home, the derivation of the tests that have gone to nursing homes, I can't detail for you. I know that working with the National Guard, there's been a number of labs that have been involved in that 55,000, the distribution of 55,000 specimen collection kits. So I can't answer exactly the derivation of where the particular assay came from as far as what was run in the nursing homes. As far as the Office of Minority Health and Health Disparities, it has been a vital contributor to our response. The director and the deputy director are engaged every day. We have just inside state government, we have a 7:30 call across the agencies throughout MDH as well as all the agencies, and we get daily updates from the Office of Minority Health, who had a tremendous contribution that began on the Eastern Shore, but certainly the lessons learned there are ones that are coming over and are going to be in full flower on the western side in the larger jurisdiction. So it's through the Office of Minority Health that the work with the local health departments on beefing up the capacity for underserved communities to be protected and to respond. That comes from that office. Also, very importantly, that office has a data team that is now digging into more of the hospitalization data for CRISP. You know, we have a racial and ethnic breakdown of our confirmed cases as well as our deaths. But what we don't have at this point, and we're digging into through that office, is to look at the rate of hospitalization, to look at how people do, how long they have to stay hospitalized, and look at what their status is when they're discharged. Are they bouncing back and relatively able to recover at home, or are they suffering from prolonged disability and need to move into a step down? So we need to learn more through that data. That's work that's underway right now through the Office of Minority Health, and we look forward to more of that. As far as the hiring goes, I've been so distracted with response. I just haven't looked at the Office of Human Resources to understand that.
Large number of Spanish speaking.
We have really relied on our staff who are bilingual. Hugely important because, as you know, this epidemic has disproportionately impacted African Americans as well as Hispanic populations, and it's very interesting that we see a very significant increase, disproportionate increase with Hispanic populations, oftentimes because of the either housing conditions or forward public-facing occupations, or both. Fortunately, we are not seeing a similar disparity in terms of deaths. That's probably because overall the Hispanic population is a bit younger. And so in that regard, we know that younger people may be just as likely to be infected, but have relatively less severe disease, fortunately. But we know that contact tracing in Spanish is hugely important. We have a very large contingent of Spanish-speaking contact tracers, as well as relying on our safety net providers, who do a tremendous amount of work, like community health workers, working in other languages.
Jerome Kelly, I believe we've picked your microphone, muting.
Okay,
excellent.
Thank you. Madam Assistant Secretary, I appreciate the work you've been doing with nursing homes. But we've got tens of thousands of seniors in assisted living, from very large settings that are parts of continuing care communities to down to 2 and 3 sharing a bedroom in someone's home. We are hearing nothing about them, and often they are much more low income and are Medicaid dependent. So I know you've got some data, but what is happening with them? Is there any systematic testing? Are there any performance audits going on? Do you know how these people are faring? And what can you tell us about assisted living?
Thank you, Senator. And yes, we do know that there's a very large population of people in assisted living, and do want to make sure that they have the opportunity for protection and to be tested if that's indicated for them. The focus on nursing homes had to be on nursing homes because of the incredible fragility, the vulnerability of people just by nature of being in a requiring skilled nursing care, as opposed to having more independence through assisted living. That's not to say that seniors in assisted living don't need to have special protections. They absolutely do. But we were seeing 53% of our deaths were coming out of nursing homes. So it was a tremendous call to action. And now, as we have successfully completed that round, we definitely want to pivot and do more, not only with seniors, but also with, as I mentioned, others in congregate settings. So we'll be happy to work with you in the future
a real problem is that many of the directors and owners of the assisted living are representative pays for these people's Social Security checks. These people are income-wise more vulnerable than the seniors who are in the nursing homes. And we have no way of knowing if they're in there dying, with the statistics not even gathered, and with their checks being held by the owners and managers of these homes, because we aren't doing anything and we don't know, and they're in so many, they're in tens of thousands of locations.
You know, the stories that you know, it breaks my heart that can be true. And I know that Secretary Kramer, Department of Aging, Secretary Kramer has developed a very, very vital program of outreach and callbacks for seniors. And so I would like to I'd like to connect you with that program and see how we can, working with the Department of Aging, really amp that up and work with these isolated seniors in oftentimes a small assisted living. That's exactly the group that we really need to focus on. So thank you for bringing that to our attention.
I'm not sure that most of them notice she exists because she doesn't have direct responsibility for them, but they are in so many different settings. In my community, the police are very often checking on those who are malnourished and maltreated, and where the owners are the representative pays for their Social Security checks. We got tens of thousands of these people. We gotta check on their health.
We do, we have to check. Thank you.
Okay, Minority Whip Shalega.
Hey, can you hear me?
Yep.
Oh, good. Thank you so much. Thanks for being on the call. We appreciate it. And I have a question similar to what Senator Kelly was asking about. First, I'll make a quick comment. My parents live at a CCRC. My dad's in the nursing home and my mom is in the independent living. And Bill Holman at Ginger Cove has had a model response to the COVID-19. You know, they've just done a terrific job there with the residents, with the staff. And, you know, I would encourage you, if you're looking for model responses, to talk to them. I am concerned about visitation in nursing homes. Sent a letter off to Governor Hogan last week or the week before, asking for you to find some guidance. My mother hasn't seen my father in 3 months. And, you know, there has to be a way for these facilities. And I know Ginger Cove could make that happen, but the guidance is that no one is allowed to visit. In the meantime, I can guarantee you that my father's condition has declined, but, you know, there's no one there, family, able to talk to him or see him. And he, like many in nursing homes, cannot use technology to communicate with loved ones. So I would put in a request that you not continue another long period of lockdown, or these folks in nursing homes will, you know, die of loneliness, and it's not fair to their family members. But my question is this: when you're recording deaths from the COVID-19, are you able to determine if someone died from the virus or of the virus? And again, I'll point back to where my parents live. They've had only 2 deaths. And, you know, one of them was somebody who'd been in and out of the nursing home wing for 15 years. And she was in her mid-90s. And while she may have had the COVID-19, you know, her medical condition was frail. So are you going to separate that data out, or are you just saying everyone that dies with COVID-19 is determined to die of that?
Thank you for that question. And also for your observation about your parents. And I feel for you and for them. And I know this has just been extraordinarily hard. We are working, we're trying to get guidance from CMS around, as other states are, on how to so cautiously reopen, under what conditions could there be some visitation for skilled nursing home folks. And the first step is the kind of universal testing that has been done now. That's the very first step. Set in motion serial testing, but it's just been a tremendous hardship, I know, for families everywhere. It's just very, very difficult. As far as deaths go, the Maryland reports confirmed as well as probable deaths, and that's important because it's a distinction. If the cause of death on the death certificate is COVID disease, that's a confirmed case. However, it's also important to capture people who may have succumbed to other kinds of chronic diseases, but for whom the attending physician indicated somewhere on that death certificate that it was a suspect case or it was a probable case. Perhaps the person was not actually tested, so it's not confirmed. But those are very important deaths to capture as well. So both confirmed and probables are reported by Maryland every day. And we're unique in that in other states. If you look at how we are reported in the Washington Post, for example, our deaths those are combined, both confirmed and probable. That's not exactly apples to apples in comparing us with other states, but nevertheless, we wanted to be as transparent as possible in that regard. The last thing I'd say is our medical examiner has, through their forensic investigators, have been trained so that if they do find unwitnessed deaths where there is any kind of suspicion of COVID, if it is possible to posthumously take a specimen and to run that in the lab, they do so in order that we don't have any COVID deaths that are unrecognized and unreported.
Thank you. Those were my questions.
Thank you.
All right. I believe that does it for questions. One final question to Mr. Secretary is the Speaker and I wrote a joint letter several weeks ago that we were hoping to receive a written response. Can you please give us a date certain when we can have that written response?
I will check on that, Mr. President. I will check with the the governor's office, and I will give you a specific time.
Okay. Madam Speaker, did you?
Yeah. In addition, I sent a letter, Mr. Secretary, to both you and Secretary Brinkley. It came from me, the Chair of Appropriation, Chair of Health and Government Operation, about state employees protections. We have gotten a lot of letters from them. Also, would like to get a response. No.
Okay.
All right. Well, we look forward to those responses. We appreciate the work that you have been doing in the midst of this, and hopefully the trends that we've seen continue as we move forward, and appreciate those efforts. So thank you, and we look forward to an ongoing conversation as we kind of move into the next phase of this this pandemic. So thank you for your work, and we will be in touch.
Thank you.
Madam Speaker.
Thank you.
Okay. Is Dr. Inglesby still with us?
I am still with you.
Okay. Thank you for your patience, as was referenced by both the Secretary and the Chief Operating Officer. We are joined by Johns Hopkins Director of the Center for Health Security, Tom Inglesby. He will give us some insights on where we stand as a state and a nation with COVID-19, as well as where we go from here. Dr. Inglesby, again, thank you for your patience.
Thank you. Thank you, Mr. President, Madam Speaker, distinguished representatives. I really appreciate the chance to speak to you. And I was asked to give a few comments on the reopening process in particular, and the trends we're seeing, as well as the potential for spikes around COVID, around the COVID demonstrations and the timing of that, should they occur. So I'll start by saying I think that the Maryland state response to the pandemic and the reopening efforts have been moving along in a practical, risk-based way. I've had only a few concerns along the way, mostly about church reopenings, because I've been concerned about the risk there, but I understand that was dictated by legal requirements at the state level. But overall, I have seen early good social distancing decisions made by the state and a substantial, well-resourced multi-agency effort unfold over the last few months, and a stepwise reopening process that's underway. In terms of the conditions for reopening for the state, I think we've been moving in the right direction. ICU beds occupied by COVID patients at the peak were 611, and that was a few weeks ago, and now they're down to 481, so moving in the right direction. And total beds occupied by COVID patients were as high as 1,700 back on April 30th, and now are down to 1,100. So at this point, it does seem like in-hospital capacity exists in the state to deal with current COVID patients, and probably modest rises. We'll need to keep close watch on those as elective procedures begin and people begin to go back to hospitals for more medical care than they were in the last couple of months. And that is obviously happening at the same time that the process of reopening is occurring. So we'll need to monitor that carefully. And of course, there are a range of alternative care sites set up as described by Mr. Schrader. Should we need those? Hopefully we won't. But it's been very good preparation in the event that we do have future spikes in disease in the state. You've seen the results of improving testing from Secretary Phillips, now down to 9.5% positivity from a high more than 20%. And this is really good progress. We need to continue to drive those numbers down in the weeks ahead to less than 5% and lower as possible. And I think that's likely to happen given the pretty substantial rise in diagnostic testing that's occurred in the last 2 weeks. It's been a pretty substantial number as compared to the weeks and months before. And in terms of contact tracing, I don't have much to add to what Secretary Phillips described. I think it's very important that this process get underway and be very successful. It's been the key to managing outbreaks in different parts of the world where they've had more success than the United States. So that will be a very, very important initiative for our state in the months ahead, and coupled with extensive diagnostic testing. Those will be the key in getting this disease under control until we have a vaccine sometime in the future. Once decisions are made to reopen, in our state and other states, there are a number of principles that are most important in terms of lowering risks. And I think most of you probably are familiar with them, but just to review the most important ones: outdoors is far safer than indoors. Lower density workplaces are safer than higher density. No or low touch places are more safe than places where touch is required. Smaller groups are safer than larger groups. Prolonged exposures are riskier than short, brief exposures. The CDC defines a contact as an exposure of 30 minutes or more, which is quite substantial in terms of timing. The World Health Organization says 15 minutes or more, but you get a sense that it's not just walking by someone where the highest risk is. It's not to say that occasional transmission can occur in lower risk environments, but the higher the duration of interaction, the greater the risk. We know that activities like singing and speaking and shouting and coughing and sneezing increase the risk above just normal breathing. We also know that wearing a mask, a cloth mask at a minimum, and keeping distance of at least 6 feet substantially decreases the risk. There's a new study out this week that summarized the data for that, and again, emphasizes that those things do reduce the risk. One simple way to think about the risk in our state is related to the likelihood that you're breathing in someone else's breath. And the longer you're breathing someone else's breath near you, the higher your risk if that person happens to be infected, whether they know they're infected or not, whether they're asymptomatic or symptomatic with the disease. Touching contaminated surfaces does present some level of risk, and so cleaning is important, but most of the risk is through respiratory droplets spreading from one person and being breathed in by another. So from these principles, we can make the best practical judgments about reopening businesses and activities. And I think that those principles have been largely the drivers. I think, and I can't think of clear exceptions to that, the drivers of the activities and the reopening that has happened so far. It's really important as this process of reopening continues around our state that leaders communicate that there's no way to say that something is absolutely safe, but that what we can do is to say that things are of lower risk than others, and that as many steps as have been feasible have been taken to lower the risks associated with a particular business or a particular activity. Especially for older people and people with underlying conditions, it's really important for them to understand that there are still risks should they become ill. That just because a particular thing has reopened doesn't mean that anyone, any state or local official can say, it is now perfectly safe for you to go there. That's just important for all of our governors, our public health leaders, our national leaders to continue to say that to people so they can make informed decisions about their own lives. It's also really important for state and local officials and health leaders to continue to say how important it is to wear masks and to keep socially distant, physically distant at 6 feet or more. Some governors, I think, have been more effective in doing that than others. I think Governor Hogan and his team have been very persistent in saying that in all of the announcements. And I think will continue to be really important to be part of the message that all state leaders and local leaders convey to their constituents when they're talking about COVID-19. For most of all the reopening actions that have taken place so far, there's specific CDC guidance that talks about how to lower the risks associated with a particular business environment or an activity. And I believe the state team has continued to recommend that CDC guidance be followed very carefully, as well as state health department guidance that has also been developed for each of these activities. There's been a state team that's been working to develop guidance on all of these activities. We do need to monitor the impact of changes in reopening carefully. And from the time a change takes place or is advised or announced, I should say from the time a change actually takes place, not from when it's announced, but when it takes place, it's likely that it would be a couple of weeks at a minimum before we would see the impact in the course of the epidemic, if we're going to see it at all. And to see big changes would take more like 4 to 6 weeks, but at a minimum 2 weeks, because it takes time for people to develop the disease. They have an incubation period. And from the time someone that might get sick, it may take them days, at least days, to be sick enough to be hospitalized. We do need to be prepared to pause on the reopening process if things move in the wrong direction. If the hospital indicators in particular move dangerously in the wrong direction, it might be that we need even to reverse some of the decisions if that is the only available tool that we have at that time. Hopefully we won't get there. I know no one wants to reverse anything, and I certainly know that I've heard the governor say repeatedly does not at all want to do that. But I'm just saying on a personal level, if things were to move dangerously in the wrong direction, we don't have a lot of major interventions beyond social distancing and beyond the physical distancing measures that we're all taking already to change the course of the epidemic in terms of rising numbers. The key for state and local jurisdictions in the time ahead will be to test extensively so as to identify contacts, or to identify cases rather, and the contacts of cases, so we can isolate the cases and quarantine the close contacts as quickly as we can. And Secretary Phillips really was describing that quite carefully about all the work that goes on. It sounds straightforward, but there are many, many steps involved in that. This process is also called case-based management, and it is the process that has led to success in places in the world where things have been better. And then another metric I think the state should follow in the months ahead is the number of people that are diagnosed with this disease that come from what might be called community transmission, which is identified without any contact to an existing case. Over time, that number should come down as we get better at contact tracing and diagnosis. In places in the world like New Zealand, their number of cases that are community transmission and not otherwise related to any case are down as low as 2%. But in many places in the country right now, the majority of cases in a state are identified as community transmission. We don't know where that case came from. And over time, we need to change that. And finally, in terms of what the impact of demonstrations and protests might be, there definitely will be a risk posed by large gatherings of people. We have seen in the US and elsewhere in the world that gatherings, small and particularly larger gatherings, have resulted in outbreaks of COVID. Mostly we have seen these in indoor locations. For example, in Malaysia in February, before they were very aware of the disease in their country, in one religious event of 16,000 people that had gathered, hundreds of people got sick. That included both indoor time and outdoor time, but it was before people were wearing masks or physically distancing because they were unaware of the extent of disease in that country. In the case of demonstrations and peaceful protests now going on in Maryland, I am hopeful that many or most of those who are protesting have or will be working to keep themselves and their families as safe as possible so that they can help try to prevent themselves from getting the disease or spreading the disease inadvertently. And they can do this by wearing masks in public and by trying to keep as physically distant from others as possible, staying outside, staying in smaller groups as opposed to larger groups. And given that asymptomatic people now are about 35, we believe, at least the latest studies say that they're about 35 to 40% of those with the virus, everyone should be doing these things, not just people who might have any symptoms or who think they have the virus, but everyone, because we don't know if we have it asymptomatically. We also know that loud shouting contributes to the spread of the virus. So recommendations to protesters have been to consider using other kinds of noise-making devices or drums and to try and minimize shouting just because of the potential for increased spread in people close to them. I do think we should be prepared for the possibility of a rise in cases in the next 2 to 4 to 6 weeks, possibly related to this, but I hope that widespread individual actions as people are engaging in these important events are going to be enough to try and blunt the potential impact of a rise. So with that, I'll stop and see if there are any questions. Thank you.
Don't see any.
Madam Speaker, I don't see any. If they're just a very briefly, Dr. Ingersby, first, thank you for your work throughout this and your advice during this entire process to us in the General Assembly and certainly to the governor as he's moved forward. Just your level of confidence in where we are and moving forward. If you could discuss just generally your in your opening remarks, you stated it, but just, sort of a concise, how do you feel moving forward right now?
I feel like I do feel confident in the plan that has been established so far. I do feel like diagnostic testing is rising quickly. I think hospital numbers have been improving. I do think there is extensive alternate care site capacity outside of hospitals that's been established over the last couple of months. I think we'll see how the contact tracing effort goes. It's already, I know, underway, but in some ways it's really just getting going. But I do think that the plan that's been laid out is strong, and we'll have to see how it works in our communities around the state. I do think the governor is paying very close attention to the details of this. I think he knows all these numbers every morning. It seems like he is fully invested in this, and his team is clearly very, very attentive to what's happening. I think the harder decisions are coming. Some of the hardest decisions are coming, and I don't think there are clear answers to those yet, including issues around indoor restaurants, entertainment, larger gatherings, school reopening, university reopening. All of those activities will have more risks than the things that we have so far talked about or have been reopened, and each of them is a matter of kind of national study and debate and scientific study. So I think that's going to be challenging. Those steps will be challenging for the state. But I do feel like the state is moving in the right direction. Obviously, we still have people getting sick and dying from COVID, and that's tragic every day. But I do feel like, at least as compared to a month ago, that at least the trends are moving in the right direction. And this is, for the state and for every state, trying to find the balance between having people get back to their lives and their jobs and trying to stop the terrible economic loss that's been happening, and finding a balance. I think every state will be struggling with that. And this has never happened before. So every state is going to have to be monitoring that really carefully and trying to see whether it's making the right decisions. And as compared to other states, which we study at our center, I don't see other states that are making better or different decisions. I think in many ways, Maryland has been more careful and methodical than many other states so far. And I think Maryland's decisions early on around social distancing were very good and decisive and earlier than other places. And I think that probably has saved many lives. It's very difficult to know that exactly. You can model that, but you can't know for sure. But I do think that was really important. And now, in some ways, those were more clear decisions and could come quickly. Now the decisions about reopening, each one is complicated and has to be weighed. And so I do have confidence that people are doing the best that they can do. And I think communication is always going to be, there's so much going on every day and around the state and around each of the counties, that kind of understanding all that's going on is a huge job. Just understanding the state of affairs, diagnostics and contact tracing, hospitalizations. It's an enormous data management problem. But it was useful for me to see in the last hour a lot of the statistics that were presented, because there's just so much that changes every week.
Great. It looks like we do have a question from Senator Roosevelt.
Oops. Thank you very, very much. I represent College Park in Prince George's, and you raised colleges and you raised schools. In Europe, they've started to open up some of the schools.
Yeah.
I just like your general thoughts right now. It'll change. You'll get more information. Looking at what's happening elsewhere in the world and to some extent in the United States, where do you think we are in terms of being able to safely bring kids back to school?
I think that there are different problem sets with K through 12 versus universities, because universities have the additional problem of congregate living and dorms and shared bathrooms and food, et cetera. On the K through 12 side, it's still a big debate in the public health community. I think everyone agrees that it's been terrible for children to be out of school for so many reasons, educational reasons and support reasons and safety reasons. On the other hand, we haven't had a lot of experience with schools being open since this started, because most schools all shut down around the same time around the world. And we are beginning to learn about the experiences of European countries and, for example, Israel and Taiwan and how they're doing that work. We just issued a report on the kind of the research questions that we think are fundamental to answer before making final decisions. But I think for kids in general, if we were to open schools today, I think kids will be at low risk, but not zero risk. There are kids who are going to get sick from this, unfortunately, and occasionally will have a severe outcome. The bigger concern is the grown-ups in their lives and whether they might, what is the chance they're going to bring risk back to their parents or to their teachers or administrators, or if they live in a home with their grandparents. And those questions haven't really been answered by research yet. We don't really have statistics on that, so it's basically a judgment. And I think different states may decide different paths. And I know Maryland has been thinking very hard about it. And I don't know what the decision process is yet on that, but it's early data on K through 12 schools suggests some places have done well with minimal disease, but then in other countries, like for example, this week in Israel, there was an outbreak where more than 225 people have been infected in a school system after reopening. So we're going to have to find a way to tolerate some level of risk and balance all of the good from schools with some level of risk for spread.
Thank you.
It looks like we do have one last question from Senator Lamb. One last brief question.
Sure. Thank you, Senator Ferguson. My last question has to do with, and thank you, Tom. Good to see you again. With the state's reopening and WHO recommendations, for example. I know WHO has recommended right below 2% for positivity when it comes to having enough testing capacity. And based on Hopkins's positive rate tracker, Maryland is the fourth highest positive of any state in the country. So, given that background, should we be comfortable with directions that the direction that we are moving when it comes to reopening and the speed at which we're doing that? And, what's preventing us from getting our positivity rate down to those recommended levels? Could you clarify that?
Yeah, I think we should drive the positivity rate as low as we can. And I think that would be great to get it below 2%. I think the rate of change has been, I have been concerned about the high positivity rate. And I know that the state has been very concerned about it for some time. And I don't know all of the details about, why, in a given week, we've had diagnostic testing at a certain level. I just haven't been as tightly involved with that as the speakers who came before. But what I can say is that the last week, the number of tests week or 10 days, the number of tests that have been done has been dramatically different, dramatically more extensive. And the rate of positivity has gone from above 20% to 9% in a relatively short period of time. And my intuition, just looking at the numbers, is that we will be in low single digits relatively soon. So I think that trend is a good trend if it continues. I think you're right that we should drive the number as low as possible, and that does correlate with better outcomes. And it sounds to me, just listening this morning, like that is the plan from the state.
All righty. Bill?
I think that does it. Thank you again, Dr. Inglesby. Thank you for sticking with us in the time. We very much appreciate it and look forward to your ongoing insights.
Thanks so much for having me.
And thank you to members for sticking through a little bit of an extended meeting. Pleased to have the Department of Health. Only final comment before we close out from me is that just to remind members to check the website. We are the standing committees on are regularly meeting, and so those dates will be updated on the Maryland General Assembly website as those hearings continue forward. Madam Speaker.
Okay. And for me, just a reminder, our next meeting is next Wednesday, June 10th at 10 a.m. Thank you, everyone.
Thank you.
Safe.